Um, so in order to start my right IJ central line, I like to set my room up, get my patient at about waist height, and put them in some Trendelenburg. After doing that, I like to do my prep non-sterilely before I start. So I have my prep here, and position the patient with their head looking away from the side I'm going to. So I'll do my prep here, starting over the two heads of the sternocleidomastoid and move outwards. I like to go, my upper limit is usually the ear. I like to go way over, almost to the other side, almost to the other sided vein, down as far as I can go to the bed here, and then to the nipple on for an inferior extent. That gives me some leeway on my draping, and also if I end up doing a subclavian, it's helpful to have that extra stuff prepped in so I can just adjust. This becomes garbage. And while the prep dries, I go ahead and get sterile. I'll take off my gloves. I may need a little help getting into this gown without messing this up. Okay. Usually I would put my gloves on using sterile technique, but because we have different materials today, I'm just going to put them right on. All right. So I'm now sterile and ready to get started. My patient's prepped, so I can go right ahead and drape. Look at my drape and see the orientation. Guy right there tells me which way it goes on. I like to put the hole right where I'm going to be working. This sits down. And hopefully goes on. I would ask one of my nursing colleagues to help me bring this towards the end of the bed, and this comes up over the patient's head. Keep going just a little bit. Okay. I'm going to skip removing the adhesive today so we can preserve our drape. So now I'd just like to briefly prep my materials here. I always know the first thing I'm going to need is my ultrasound and my lidocaine. So I have a little bit of lidocaine already drawn up here that came from this bottle. So I usually draw up a few cc's. The next thing I'll need, I know, is my finder needle, which is close enough here. Here's my finder needle. The next thing will always be my wire, and I like to check the wire. Right now I notice that I'm missing my little blue piece that holds the under. Okay, good. So this is what I was missing. I can just put this on here. This little piece helps you easily thread the wire into the needle without fumbling around more than I usually do. And this was a little unwound. Okay, so that's ready. I can flush my ports here. I'm going to have to borrow my finder needle to do that. There's a cap already on here, but we'll save that for the end. I'll unclamp all my ports to flush. With some saline. See that they all come out. 1, 2, across the room, that means it works. And 3, okay. So I like to clamp the white and the blue port, because I'm not going to need those for a while. Prevent extra bleeding on the bed. And then this guy's ready to go. So the first thing I'm going to get started is get my ultrasound probe, which we're going to skip the draping today for expediency purposes. Looks like it already has some goo on it, and see if we have enough. So I can see both my landmarks. I like to make sure I have my orientation correctly by moving medially and seeing that I move towards the artery, and then moving laterally and seeing that I move towards the vein, and then go ahead and get my vein centered. I can confirm as well that the vein is nice and compressible while the artery is pulsatile. So this right here is my vein. And then go ahead with my lidocaine, and I position it pretty much just as I would my finder needle, so right in the center of my probe. I enter the skin, and I should see it start to come into view. There it is. I'm not going to enter, but just anesthetize the skin, so I can see my wheal forming there. Means I'm done with lidocaine. I'm going to put that in my Sharps protector. So at this point, I give it a minute to work. It gives me a second to set up my binder needle. I would usually wait a little while to let the lidocaine kick in, but we'll just keep going for now. So I can see that I've set up between the two heads of sternocleidomastoid, but I'm doing ultrasound guidance, so I'm not really that worried about my landmarks, besides just being at the right level in craniocaudal. So here's my finder needle. I'm going to position it right at the middle of my probe, start to advance in, pulling back all the way. Looks like I have a blood return. So I'm going to put down my probe, careful not to drop it, confirm that I still have return, and remove my syringe. And go ahead and get wire access now. As I advance my wire, I know it's a little difficult because of the model. Usually if I encountered resistance, I'd have to stop and maybe retry. And usually stop when I'm satisfied I have enough in the patient that I have access and before I get ectopy. So at this point, I can take this stuff off, re-grab my ultrasound probe, and check that my wire's in the vein. You can see it right in the middle there, and I like to get a long axis view as well. You can see not that great detail, but there it is. There's the wire entering the vein. So I'm pretty confirmed that I'm in the right spot. You can move medially and see the artery. Nothing in there besides flow. So happy now I can take my needle out, and I'm going to go ahead and make my nick so I can pass my dilator. That's done. Sometimes that bleeds a little bit. I have to just keep a gauze over there to prevent the patient from getting wet. So now I'm going to pass my catheter in, keeping control of the wire. Here this goes. Now, sometimes you have to pull the wire back a little bit to see it come out that red port. Now I see it back here, so I can grab here and advance at the skin. At the IJ, usually going in about 15 centimeters in an average size patient. So 15, it's going to be not quite yet. That's about right. Okay, so now that I have my catheter in, I'll take out my wire. Put that over here. To confirm that I'm where I think I am, I'd like to withdraw venous blood. I'll start from the open red port. I like to have a little bit of saline in here when I do this. So I'll start here, withdraw back until I see some venous blood, which is, well, being stubborn today. So I have air, which in our model is going to be the same as venous blood. In a patient, it would not be the same. So I'm going to clamp off that port, move to the next one, unclamp, withdraw first, and then I would flush saline in until it was clear. Clamp that one off. Then I'd open this one up, withdraw, and then until I saw blood, and flush saline in until it was clear, and then clamp off. So I'm satisfied that I have my line in a good position. I want to go ahead and sew it in. Looks like we have a stat lock for that. The stat lock goes on here, usually right near the skin. This little blue piece locks it on. And then I take my stitch, and with a needle driver, if we had one, I would put in stitches in either one of these blue holes, probably after doing some more lidocaine, which I guess I can show you. A little bit of lidocaine left over, I can put it in these areas so that they don't feel my stitches going in and get angry at me at the end. Secure that. Then I would put on my sterile dressing, and the last thing I would do would be to add these caps to our ports, all three of them. Unclamp these so there's no confusion. So I'd have a sterile dressing on here, we're capped, we're sewn in, and I would then go ahead and take the patient out of Trendelenburg, undrape, and call for a portable chest X-ray.